Good evening. Welcome to Living with Ovarian Cancer webinar hosted by the Florida Society of Clinical Oncology. FLASCO is a member-supported state society that focuses on supporting and representing the oncology workforce in Florida. FLASCO is the voice of oncology in Florida. Many of the individuals presenting and participating in this webinar are members of FLASCO, and we appreciate their support. My name is Robert Holloway. I'm the Medical Director of Gynecologic Oncology Program at Advent Health in Orlando. I'll be serving as the moderator tonight. Our topic, Living with Ovarian Cancer. Our oncology experts will discuss the disease itself and treatment options, and then move on to more focused areas, including support for caregivers, advocacy, and ovarian cancer resources. To begin the presentations, we'd like to thank GSK, that's GlaxoSmithKline, for sponsoring this webinar and making it possible for us to share this important information. I'd also like to let everyone know that this webinar is being recorded so that those who are unable to attend can view this at a later date. Please note that your lines will be muted during the duration of this webinar. Toward the end of the meeting, we will host Q&A and encourage you to submit questions or comments via the Q&A chat feature at the bottom of your screen. We will discuss as many questions as time permits. I'm honored to introduce our amazing group of panelists. I will briefly introduce them, but please read their impressive bios in the meeting material that was emailed to you. Now I'd like to introduce Dr. Natalie, is Director of the Gynecologic Oncology Fellowship at Advent Health. Dr. Mackenzie, or Dr. Heather August, I'm going to butcher this name, Augustniak, Director of Baptist Memorial Hospital in Anderson, in Jacksonville. And Marlene Morales is a licensed clinical social worker at the Sylvester Comprehensive Cancer Center. Lastly, Dr. Michael Diaz, President and Managing Physician at Florida Cancer Specialists, is Director of Patient Advocacy for the Florida Society of Clinical Oncology. We want to thank all speakers for their time and knowledge that they'll share with us today. I will now begin the presentations. This is the second year that we've done this, and while I didn't really ask for this time, we were kind of advised last time to keep this more conversational and informal, so I did not prepare a slide talk this evening, and literally just walked in from my office where we've been seeing ovarian cancer patients all day. So I think I was tasked with just the general question, what is ovarian cancer, in a general overview, and I've got probably another 15 minutes or so, and then we'll have Dr. Mackenzie speak on treatment options. When we speak about ovarian cancer, we typically are speaking about the most common types of ovarian cancer, and those are called epithelial ovarian cancers. Epithelial ovarian cancers comprise a number of cell types and histologies. They typically are present in patients who are menopausal. The median age of high-grade serous carcinoma is typically around 60 to 62. And that's a bell curve with a range. We certainly do see these cancers in reproductive age women, but the vast majority are postmenopausal and can be into the very later years of life in the 80s or 90s. There are also epithelial cancers called low-grade serous carcinomas that do occur more commonly in a younger age range, perhaps median age more around 50. And then we have other more uncommon types of ovarian cancers, the stromal tumors and germ cell tumors. Stromal tumors make up about 5%. These are covering the age spectrum from young women up into postmenopausal women, and can be hormone-producing tumors producing testosterone and estrogens. We have germ cell tumors, which are characteristically more in young women from teenage years up into 20s. that come actually from the germ tissue of the ovary. These are similar to male testicular tumors. So the vast majority of patients that we treat with ovarian cancer have the epithelial carcinomas, and all of these tumors, all of these can be treated primarily with surgery and chemotherapy type varies on the histology and the type that we're speaking of in particular. So I think for the majority of the time, we're going to confine our comments to the more common epithelial ovarian cancers. For many, many years, these cancers were described as silent, but we know now that they really aren't silent, that many women have symptomatic complaints that will be passed off as gastrointestinal in origin, like irritable bowel syndrome, chronic constipation, chronic abdominal pain syndromes. And so it's important that a patient or a woman who has a change in her bowel habits or urinary habits or a change in pain characteristic be evaluated first with a visit to the gynecologist and a pelvic exam, maybe an ultrasound. But oftentimes patients get passed around, usually with a full GI workup, and then eventually end up finally getting a pelvic exam and a diagnosis of pelvic mass is made. So it's important to consider changes in bowel habits and bladder habits could be gynecologic in origin. We don't have pap smears for ovarian cancer, which is the main reason the majority of patients with ovarian cancer present with an advanced stage disease with spread into the upper abdomen. So unlike cervical cancer, where you have a pap smear, or even uterine or endometrial cancers will present with postmenopausal bleeding, spurring, and early diagnosis, there really is no diagnostic or a screening test for ovarian cancer other than annual pelvic exams and paying attention to signs and symptoms. One bit of good news is that the overall incidence and therefore deaths from ovarian cancer have been slowly declining in the recent decade due to a number of factors, but one of them is risk reduction surgery. So we recognized that there is a predisposition to ovarian cancer through genes, primarily BRCA1 and 2, but also a number of related genes in these pathways that can predispose a patient to ovarian cancer. And understanding this, and as patients with ovarian cancer are now routinely screened for these genes in the United States, this allows for what we call downstream testing, such that if a patient with ovarian cancer has a genetic predisposition, her children have a 50-50 chance of inheriting the gene. Her sisters would have that 50-50 chance, and brothers. And so that the entire family can now be screened for that gene deficit. And if it's present in the family, the possibilities for more intense screening at a younger age and then risk reduction surgery can be entertained to prevent ovarian cancer, as well as breast cancer in the setting of BRCA. So I think this is starting to bend the curve on incidence, and with more screening and more detection of early stage disease, we get better outcomes. Let me see here on time. I've probably got another 5 or 10 minutes. So what is ovarian cancer? I think back to the other factors associated with ovarian cancer, birth control pills are actually protective. Having children is protective. And so interruption of incessant ovulation has been shown to be protective. Endometriosis, which is a common benign gynecologic condition, increases the risk of ovarian cancer. And that's probably cancer arising in the endometriosis itself, which then affects the ovary. So treatment of that disease can be protective in preventing ovarian cancer. I think in the future, we hopefully will have a screening test for ovarian cancer with more or less a liquid biopsy looking at DNA fragments in the blood, which could predict the earlier onset of ovarian cancer, such that hopefully in the future, along with a mammogram and a pap smear, hopefully there will be a blood test in the not too distant future to assess for the potential for ovarian cancer, which would then lead to more intense screening for early stage disease. I think on the Dr. McKenzie is going to cover treatment options. I would just say beyond treatment options, areas of research in ovarian cancer are screening blood tests for early detection. And then on the, I think the biggest news on the treatment side is more directed, targeted therapies based on these gene mutations that we find in ovarian cancer, along with the use of immunotherapy. And this is an emerging field of therapy in oncology that has had a strong foothold in many cancer types, not so much in ovary to this point because these tumors tend to be more stealthy and evade the immune system. But more and more research is coming to determine how we can use immunotherapy to augment our current therapies for the maintenance and even cure of ovarian cancer. And I think we'll see more traction, more research on this in the coming years, using immunotherapy with other therapies to affect good outcomes in ovarian cancer. I think at this point, I will turn over the discussion to Dr. Natalie McKenzie for discussion of treatment options for ovarian cancer, and then we'll move on to survivorship. Natalie is my partner at Advent Health in Orlando. She's very interested in quality outcomes in ovarian cancer, improving quality of life as well as longevity. She's from Miami, did her oncology training at the University of Miami, has been with us for over 5 years now at Advent Health. And with that, Natalie, I'll have you take over and discuss treatment options.
Wonderful. Thank you for having me, FLASCO, and thank you for the introduction, Rob. So I want to kind of simplify things for our audience. So when we think about treatment for ovarian cancer, of course, Dr. Holloway mentioned that there are different types of ovarian cancer, the epithelial, we have the germ cell, and the sex-squared stromal cells that are considered the more rare types of ovarian cancer. So if we can certainly talk about those as well, but if we focus on the most common epithelial types, I have to add that when we talk about ovarian cancer, we're lumping in primary peritoneal carcinoma and fallopian tube in that category because they behave the same, they present similarly, and they're treated exactly the same, regardless of primary peritoneal, ovarian, or fallopian tube. Moving on to treatment, for patients who have these disease types, we typically lump them into two major categories. The patient group, the patient population who we think we could offer surgery to, whether they're diagnosed at early stage and they're having the uterus, tubes, ovaries out, lymph nodes, omentum removed, or a very big cancer surgery involving certain other organ types, or those who are not amenable to surgery up front. So we tend to use the word debulking or cytoreduction when we're talking about surgery for ovarian cancer. You'll hear us use that a lot. And patients can either be grouped into the primary debulking or cytoreductive surgery group, or those who are going to receive chemotherapy first. And chemotherapy that's given ahead of surgery is called neoadjuvant chemotherapy. So when you hear us talk about neoadjuvant chemotherapy, we're talking about chemotherapy that we start before we get to surgery. And the hope is that the chemotherapy will reduce the tumor burden and allow for surgery to occur at some time point later on. Typically, historical data and research data has suggested that we would offer 3 cycles of chemotherapy, 3 to 4 cycles of chemotherapy, and then attempt a cytoreductive procedure, which is followed by more chemotherapy. That historical data is being brought into question now, and there are some studies that are looking at whether it has to be 3 to 4 cycles, can it be 6 and then surgery? So that's to be determined. But for now, the great majority of GYN oncologists throughout the country typically offer 3 to 4 cycles chemotherapy followed by surgery, then more chemo. There are some patients who are not all going to respond well to platinum doublet agents, or even the third drug that we use, which is bevacizumab. So let's talk about those drugs. For a long time now, we've settled on the platinum and the taxanes, and recently we added bevacizumab for certain patients. And this monoclonal antibody has been shown to help certain ovarian cancer patients respond to treatment better, and especially if they're advanced. Another reason we tend to use this monoclonal antibody is for patients who tend to have a lot of ascites. Excuse me one second. Excuse me. So we start off usually with a carboplatin paclitaxel plus or minus bevacizumab. Patients can then be lumped into 2 groups, or rather 3 actually. The group that's going to respond to platinum therapy, the group that is not going to respond to platinum therapy. And of those who respond to platinum therapy and eventually undergo surgery, chemotherapy, neoadjuvant chemotherapy, adjuvant chemotherapy, these patients, many patients will undergo remission, approximately 80%. But then the cancer can come back, okay? If the cancer comes back within the first 12 months, we consider that to be platinum partial response, partial sensitivity, 6 to 12 months. If it comes back less than 6 months, we consider that platinum resistant, and greater than 12 months, we consider that platinum sensitive. Now, this partial sensitivity thing is a very new thing. It's not very long since we started using this partial sensitive term. For a very long time, we group patients into greater than 6 months or less than 6 months. And that's the standard that we've been using for a very long time. So when patients recur less than 6 months, they're assigned a category, if you will, of being platinum resistant, and greater than 6 months, platinum sensitive. And being platinum sensitive or resistant is very crucial to us in our field, because we use that data, that categorical data, to assign treatment strategies for our patients based on platinum sensitivity or resistance. Now, let's scale back a little bit before we get to that. We have to talk about maintenance therapy. Maintenance therapy, there are 2 different categories of drugs that we currently use for maintenance. The monoclonal antibody, the bevacizumab that I previously mentioned, was shown in studies to decrease recurrence and increase progression-free survival for patients who continue on this monoclonal antibody for up to 18 months beyond the cytotoxic chemotherapy with the carboplatin and paclitaxel. So that's one strategy. Another strategy is to use another class of drugs called PARP inhibitors. And PARP inhibitors were found to have this overwhelming overall survival maintenance for patients who are germline BRCA mutated. We've also found somatic mutations to play a role in that. And so this was a huge breakthrough for patients who were BRCA positive to benefit from overall survival. We've since subsequently found that the PARP inhibitors can be used for platinum-sensitive patients as well, and that was another breakthrough. So this class of drugs, the monoclonal antibody and the PARP inhibitors, have really changed how we practice GYN oncology and benefited our patients immensely in terms of overall survival. And the PARP inhibitors were tested after first-line maintenance and second-line maintenance, and there were other indications as well that have recently been pulled. But we see that patients benefit, especially those who we believe are platinum sensitive, and that speaks to how the drug works, specifically in the inhibition of certain DNA repair, especially for the tumor cells that have a certain weakness. We call that synthetic lethality. So now you know a little bit about how we classify our surgical patients, those who are going to have surgery up front or have interval surgery after neoadjuvant chemotherapy. We've talked a little bit about platinum sensitivity. We've talked about maintenance therapy. And now it's time to talk about recurrence. So unfortunately, 80% of our patients do respond, but eventually the cancer comes back. So what do we do when the cancer comes back, and how do we monitor our patients? First of all, we tend to use the CA-125 tumor marker, but it's an imperfect monitoring system. And really, we've used it because we haven't had anything better than to use this blood test. But we're also investigating other strategies like circulating tumor DNA, and potentially, hopefully, other strategies as well will come to play. So until we perfect our ability to monitor patients on chemotherapy, we do have the CA-125 and we do have CT scan imaging, and of course, symptom assessment and physical exams. These are all crucial in monitoring our patients. For patients who do recur, we have historical strategies, cytotoxic agents that we know have worked for our patient population. But one of the things that's really great is our ability to perform molecular profiling for our tumors, and that helps a lot. And being able to identify the weakness, I like to call it the Achilles heel of a tumor. If we can detect the Achilles heel of a tumor, then we have a strategy to attack it. And rather than what we did previously, is to just go down the list of all the drugs we know have activity in ovarian cancer, we now have an opportunity to perhaps target the weakness of said cancer based on their molecular profile. And with that, we're discovering new drugs. For example, there's a drug that hopefully will be on market very soon that attacks the anti-folate receptor. Okay, but it's not FDA approved yet. That may occur in November. But for recurrent ovarian cancer, there are several strategies there that we can use, and several different cytotoxic agents that we can use that can either be used in combination or as single agents. We pay close attention to our patients' toxicity from prior treatment to determine the best treatment for said patient. We also look at overall response rates, and we look at activity to determine what our next drug is going to be. So if we have a platinum-resistant patient, for example, one of the favorite strategies to use is weekly Taxol and bevacizumab, but it's not the only strategy. There are several drugs out there. This is where clinical trials come into play. Clinical trials potentially offer patients the opportunity to be the first to receive the next best new drug. Now, yes, it's true that some clinical trials end up being negative trials where the drug isn't necessarily better than standard of care. But oftentimes we're able to make breakthroughs, and we're able to offer patients novel, effective new drugs earlier than when they go to market. And we're also able to help other patients benefit from those drugs by participating in clinical trials. So I'd like to take a pause here and ask Dr. Holloway what clinical trials we have for ovarian cancer at present.
Currently, we have 2 clinical trials for platinum-resistant recurrent ovarian cancer. This tends to be the major area of unmet medical need. As you stated, the majority of patients eventually do relapse, and after several lines of therapy, eventually start having progression-free survivals that are shorter. And we, as you described, term that as platinum-resistant. So we have one clinical trial that is using a novel antibody directed at a GAS6 receptor, which is a tyrosine kinase metabolic pathway. And this is overexpressed in approximately 80% of patients with ovarian cancer. So it seems like a great target for ovarian cancer. It's combined with weekly Taxol, which is the most active platinum-resistant single-agent regimen that we know of from the Aurelia trial. And then the second platinum-resistant protocol is using the oncolytic intraperitoneal virus construct that we perhaps talked about last year. This is now a national phase 3 randomized trial, multi-institution. It is currently opening in about 25 institutions with a goal to open about 30 to 35 institutions. This involves introducing a live virus into the peritoneal cavity, which infects tumor cells, multiplies many times, and eventually kills the tumor cell, releasing the foreign oncoprotein from the cell, which would then energize the immune system to attack these damaged cells and survey for those oncoproteins on the other living cancer cells. So that's a national phase 3 trial that we initiated at Advent Health. We recently closed a clinical trial in platinum-sensitive disease, but are looking at other trials to open for platinum-sensitive recurrent disease. And we have 2 upfront treatment trials in primary therapy, one using an antibody vaccine concept with standard carboplatin Taxol chemotherapy in a randomized fashion with standard chemotherapy, and the other introduces an intraperitoneal construct that is increasing an interleukin, which is a immunostimulatory agent, to again try to energize the immune system into fighting the cancer along with chemotherapy. So I think you can see just from the trials we're opening at Advent Health, there's a common theme in many of them, either with targeting a specific agent that is unique to ovarian cancer or a unique receptor, or getting the immune system involved with fighting the cancer with chemotherapy.
Thank you. So speaking of the immune system, when we think about opportunities to biohack the immune system, we have the oncolytic virus strategy, and we also have other immunotherapy drugs, which also allow the cancer to be detected, right? So immunotherapy kind of works like removing the invisible cloak, right? Cancer cells have developed via evolution the ability to evade the immune system. So when cancer cells evade the immune system does not have the opportunity to attack said cancer cells. So I tend to use the invisible cloak strategy. Well, immunotherapy allows the cancer cell to be detected, and that therefore allows the immune system to have its way with the cancer cells. That's how I explain it to my patients. So immunotherapy is yet another strategy for patients that have the biomarker positivity for that. So we have immunotherapy, we have on clinical trial oncolytic virus and other strategies. We may soon have an antibody drug conjugate. We have the PARP inhibitors, and of course we have traditional proven chemotherapeutic agents to use. Now, we're also going to talk a little bit about surgery. Surgery can have its role in recurrent ovarian cancer, depending on the quantity, the tumor burden, and the location. Some patients can and will benefit from a second surgery, sometimes a third. There's an opportunity to use radiation therapy depending on location and the amount of disease. So we use everything available to us in our toolbox to prolong survival for our patients. And with that, all of these tools, we've been able to take stage 4 patients, patients who potentially had what would have been a poor prognosis, and give them additional years. Just when we think it's all over, there's a new drug on the market, and we were able to add on some more months or years. So yes, ovarian cancer can be seen as a poor prognostic disease, but there have been new drugs on the horizon. There are new drugs on the horizons, and there are numerous strategies and tools with which to continue to prolong survival. With that, I'd like to shift gears a little bit and talk about quality of life. At Advent Health, we strongly believe in whole person care, and it's very important that we better understand our patients' circumstances, their symptoms, and the other social determinants of health to really bring light to the individual patient and how they're doing. So we also have a cancer survivorship program. It's called HEAL. There's one for breast cancer, and there's one for GYN cancer, and the HEAL programs are soon to be launched cancer-wide. These 8-week virtual programs really take patients, whether they're on treatment or off treatment or well into survivorship, and really speaks to resilience of the human host and improving molecular pathways and symptoms through well-known strategies, well-documented evidence-based strategies, from nutrition to physical activity and everything in between, to help patients live better, stronger, and add to that longevity. And so for those of you who didn't know, there is the HEAL program, HEAL GYN program at Advent Health, and it's a virtual program. Our next speaker who is our next speaker? Is that Heather?
Yes, it's Heather.
Hi, guys.
Agusniak.
Yep. I'm a lead survivorship nurse practitioner at Baptist MD Anderson in Jacksonville, Florida. Thank you for having me. I've been practicing in the GYN space since 2010, and I've seen all the advancements which have fortunately allowed our patients to live longer, but it comes with its own set of unique challenges for cancer survivors. And one of it is the identity of a cancer survivor. Those patients patients that are living with ovarian cancer, they may go through bouts of remission and then be on and off treatment. And they're like, am I considered a cancer survivor? And the phrase cancer survivor was created to describe the broad experience of the cancer continuum. So that's living with, through, and beyond a cancer diagnosis. So that can be somebody that's cancer-free, that's never had a recurrence, but maybe they have a serious or late complications due to the treatment itself. Or it can be someone that has been cancer-free for many years, but then has a late recurrence. Or maybe someone that's never gone into remission. It really doesn't matter the circumstance. It's just, if you've been diagnosed with ovarian cancer, you are considered a cancer survivor, and utilizing those resources available to you, like the one that was just mentioned, or maybe a clinic like mine that I have in Jacksonville, is really important. You know, in the United States, it's projected that by 2040, there will be 26 million cancer survivors. You know, and that's greatly due to improved treatment options and outcomes, but that's also an aging population, so it comes with its unique barriers. Currently, there's only 16 million survivors, so we're going to have to up the game for as clinicians and getting experts out there for our patients. So in 2020, the National Coalition of Cancer Survivorship did a survey of all cancer survivors. And what they found is that the majority of cancer patients say that they have discussed post-treatment outcomes with their providers, but have gotten far fewer information regarding exercise, nutrition, long-term side effects, or mental health support in the remission phase. And they didn't receive any information on surveillance schedule during that phase as well. So that's a big gap that we've been trying to fill across the.
Heather is speaking to, first of all, there have been surveys in Europe and the United States about provider level of comfort to discuss the new guidelines regarding nutrition and physical activity. And the great majority of providers don't really feel comfortable talking about that, because at the end of the day, you know, we're not nutritionists and we're not exercise physiologists. And in medical school, we receive 2 hours of nutrition, 4 years of medical school, right? So the average oncologist just knows that we don't want you to lose weight, and, you know, may say something like eat anything. Well, now we have molecular data and molecular pathway data to show that eating just anything is probably not a good idea at all. But the American Institute of Cancer Research is your go-to to know exactly what the research and the data shows. And some clinicians are very familiar with that data, but not all. The great thing, though, is that the NCCN guidelines, the American Institute for Cancer Research, AACR, they're actively involved in the type of research that speak to lifestyle for cancer patients. And those are reputable sites and resources that are available to all cancer patients. Even the NCCN guidelines have material that's written in easy to understand language, and the registration is free. The American Institute of Cancer Research and the World Cancer Research Fund also have patient-friendly material and easy to digest language, pamphlets, as well as references for those of you who want to take a deeper dive into that. But the recommendations are there. Not all oncologists are necessarily going to feel comfortable speaking to that data, but most, if not all, oncologists know where the credible resources are. At least they know NCCN guidelines, and there are survivorship guidelines there for patients to read through and be familiar with. So this is exactly the type of data that is presented to patients in the more robust cancer survivorship programs throughout the country, such as MD Anderson, Memorial Sloan Kettering, and here at Advent Health through the 8-week virtual HEAL program.
Dr. McKenzie, it's Heather. So sorry. My power went out and I lost internet connection, so I had to connect via my phone.
All right. Well, I think I kept your audience entertained until you got back.
Oh, thank you so much. I'm not going to turn on my video because it's pitch black. So that would do us no good. But I was listening to you for a minute to pick up, and one of the things that I would like to say is one of the most common issues that I experience with my patients that are going through survivorship is understanding how to use the CA-125 in remission, because that number never really stays the same. It kind of goes up and down. And I'm always discussing that trend with the patient, and I'm sure you do as well, where, as long as that number is trend for you, that is more sensitive than knowing that you're within the normal range. So if you have a trend, maybe let's just say 20 to 25, if you go up to 30, maybe 35, we may not be worried. We may track it a little bit more often, but what's significant is if that number doubles. And what's always challenging is if that number doubles, that doesn't always mean that we get a CT scan right away. Sometimes that means we're going to follow it monthly and see if it continues to go up, because sometimes that CA-125 can represent something that's not cancer related, maybe a stomach bug or an infection or recent surgery. Because the CA-125 blood test actually measures an enzyme that's released by benign and malignant tissues. And it can represent an inflammatory response. So it's not a perfect number, but it's what we have, as mentioned in the prior presentation, in current state. So if we do see a doubling, usually we'll get a CT scan if you're symptomatic. But in the asymptomatic patient population, that's where that can be really challenging, because sometimes the CA-125 can actually increase prior to clinical evidence of a recurrence on CT scan. So if we get that CT scan too soon, then we can give someone false hope or false reassurance that nothing's going on, when in fact in 2 months we would be able to find that clinical recurrence on the CT scan. So what I always tell my patients, it's really important to know when to call your oncology provider. And instead of giving a whole list of symptoms of what you need to memorize to look out for, what I always recommend is saying is, if there's anything unusual to you that lasts longer than 2 weeks with no explanation, head to toe, why don't you give us a call? One of our nurses will call you back, and we can kind of have that first right of refusal. We may or may not be worried, but we may say, you know what, we really want to see you next available appointment, because it could be a symptom that's concerning, such as abdominal bloating or changes in bowel pattern, or maybe you feel full too fast, nausea with eating, any pelvic pain, pressure, things like that. And, sometimes it's also just symptom related to treatment, neuropathies, or you're at higher risk for bowel obstruction. So constipation may not be indicative of a recurrence, but it's indicative of a serious complication that could be related to the prior surgery. So working in collaboration with your oncologist is going to be very important in this setting, so we can get you the best care possible. And then, some people want to also give back. And with ovarian cancer specifically, patient advocacy is really important, because we need to get the word out there to women. What are the signs and symptoms of ovarian cancer, so we can save more lives? So there's 3 foundations that I work with currently: the Ovarian Cancer Research Alliance, the National Ovarian Cancer Coalition, and the Foundation for Women's Cancer. All 3 of those are really great foundations. If you wanted to get involved, I would recommend contacting them. And that concludes what I wanted to talk about today. But if there's any questions, I'd be happy to answer them.
And we'll have time for Q&A at the completion with our next speaker, Marlene Morales, who's a medical social worker at the Sylvester Comprehensive Cancer Center in Miami, who's going to talk to us about support, financial assistance, and caregiver resources. Marlene, are you on?
Thank you so much for that lovely introduction. Hi, everyone. My name is Marlene Morales, and I am a licensed clinical social worker at Sylvester Comprehensive Cancer Center. I actually work with the Gynecologic Oncology Clinic at Sylvester. I'm the social worker for the clinic. I've been doing this for the last 6 years with gynecologic oncology patients, and I'm going to really try to summarize talking about patient assistance, financial assistance, and caregiver support, because I feel like it's kind of like all linked together. So I'm first going to talk about financial assistance. You know, when it comes to gynecologic oncology cancers and ovarian cancers, there's actually limited financial support for these cancers. I know because I deal with it every single day, and it's very hard to find disease funds that are available for these types of cancers. But one of the main websites that I do like to utilize is the Patient Advocate Foundation Copay Relief Fund. The Ovarian Cancer Fund is actually closed for this program, but when it is open, you can actually call them directly, and they can actually do an evaluation on the phone. And they actually help with, if you're approved, with paying any outstanding co-payments or medication co-payments, administration fees for doctor's visits, any outstanding hospital bills that you may have. They help with all those outstanding bills that the insurance doesn't cover. And it's actually a good grant to utilize, and they teach you how to use it. If not, you could always talk to your social worker. When these funds are closed, the grant that I always like to utilize is the Florida Cancer Specialist Grant. On the website, if you go to the Florida Cancer Specialist website, you can actually apply online. And what they do is that you upload your household bills, such as electricity, water, car payments, telephone payments, mortgage, rent. And they actually, right now, it used to be $1,500 that they used to give to the patients, but right now they provide $2,000 to help you with household bills. So that's a good way to address any financial issues. If you can't pay like any outstanding hospital bills or co-payments, because if you're trying to cover your household bills, they can actually take care of that, and then you can utilize that money to pay for those outstanding co-payments for medications. Another program that I like to utilize would be probably for the medications. I know that sometimes, like if you have Medicare, you're always going to have because these specialty medications are tier 5. So they're not always going to be covered by Medicare. They'll be covered, but then you'll have like this big co-payment of like $3,000 or $2,000 that you're unable to cover. And a lot of times there are manufacturers available that will cover, if you apply, to help you get the rest of that medication covered. So it's actually, they'll cover it for free for the remainder part of the year. So for example, Novartis is one of the patient assistance programs that I like to utilize. Clovis Cares when it comes to Rubraca, AZ and Me when it comes to Olaparib, Lynparza. Let me see. Cancer Care also has co-payment assistance overall, but they usually help when it comes to patients with commercial insurance, such as Aetna or Blue Cross Blue Shield or Cigna. Other types of assistance that are available out there for patients are transportation assistance, such as every county usually has transportation assistance available to patients to get you to your appointments. So it's always good to get in touch with your local county. I know I'm here in South Florida, so I basically work with Miami-Dade, Broward, and Palm Beach, and they have their own programs that they work with to get you transportation. Another program that just opened up is the American Cancer Society. That's always a good national program to reach out to, because they can tell you what's available nationally for you. And I believe that the Road to Recovery program is now available for patients to get transportation to their medical appointments. And sometimes, like here at Sylvester, they offer a grant that you can utilize for Lyft. So basically, the patients will reach out to us and we'll organize a ride to get them to your medical appointment and then to get you back home. We can get you like with Lyft, I believe it's that they utilize, but sometimes you can use the Road to Recovery, which is now available if there's volunteers in your area. I know it's hard to get drivers in Miami, but I'm sure if you're other parts of Florida, they can help as well. Going back to the Patient Advocate Foundation Copay Relief Fund, One of the programs that they just recently opened up for gynecologic oncology patients is the Health Equity Fund for ovarian cancer. You can check with your zip code to see if it's available to you. I know it's not available to our patients here in South Florida, but I know it's available to some counties in Florida, I believe northern and possibly towards the West Coast. I don't know if that applies to anyone, but it is available. Let's see. The Alliance for Aging. The Alliance for Aging is always a program that I like to reach out to if you're trying to look for additional help, such as applying for the long-term waiver program for Medicaid if your patients need a home health aide. It is a lengthy process, but it is worth reaching out to, at least having a caregiver reach out to them. Let's see. So going into caregiver support, because I feel like it's all related, because as a caregiver and financial assistance, you are caring for your patient and your loved one. And that could be a heavy load on that individual. So always reach out to possibly a social worker at your cancer center to see if any of these programs are available. Sometimes just even getting that financial assistance by applying for the Patient Advocate Foundation or the Florida Cancer Specialist Grant is going to take a load off of you, especially if your loved one and patient is unable to work because they're in chemo or radiation treatment. So those are always good programs to look into. There are also caregiver support programs. So within these programs of the Florida Cancer Specialist and the Patient Advocate Foundation, if you look at the different programs, like in the websites, they actually give you like additional cancer resources for you, whether it's financial or when it comes to emotional support. So for example, one of the really good support programs and lists that I saw was in the National Ovarian Cancer Coalition. They actually have like a whole pamphlet of like what to look out for when it comes to caregiver support and what to look out for in yourself when you're caring for the patient and your loved one. Always make sure to check in with yourself and realize what's happening with you, because if you're not good, you're not going to be able to care for that person. Make sure to check with make sure your medical care is good. Make sure you're taking care of yourself, that you're finding balance, that you're addressing any type of anxiety or depression. If you're unable to sleep, if you're not eating, if you're feeling overwhelmed and, crying, this doesn't only apply to the patient, it also applies to the family and the loved one. So make sure to check in with yourself, check with your healthcare provider, if there's a social worker, if there's other programs at the cancer center that can help you, such with financial services, which will take a big burden off of you, and even chore services. So for example, I don't know if anybody's heard of Cleaning for a Reason, but Cleaning for a Reason is actually a volunteer maid service that's available for patients. You can actually apply online. If you Google it, Cleaning for a Reason, I'm not sure if it's cleaningforareason.org or if it's cleaningforareason.com, but you can actually do a short referral form, sign on as the patient, and then they will reach out to you. And how it works is if you are a patient that's going through chemotherapy or radiation, they will provide about 4 to 8 hours of maid services to go out to your home and actually clean your home. So this will not only take a burden away from the patient, but it will also help your loved one or family that's also caring for you if they're trying to take care of not only you and what you're going through, but maybe the household itself. It's always something that I like to look into. Here at Sylvester, we have available programs such as the caregiver support groups. We have mentorship programs for GYO patients, for breast cancer patients, psychiatrists and psychologists that are available for the patients. But when it comes to caregivers, always check in with your own insurance plan to see if you really do need to talk to somebody. If you are feeling depressed or anxious and you feel like you really can't deal with it on your own, try to reach out to see if you can talk to somebody, because talking it out is going to help, even if you think it won't. Don't keep those feelings inside. Be okay with yourself in order to help other patients. If there's any questions or anything that I can answer afterward, I'm happy to help. I hope that helps. Thank you so much.
So, I tried to answer in a general sense a common question that is, what's new on the horizon? And that's, I think, is targeted therapies and immunotherapies. I think a common question that comes up is patients are not statisticians, and they oftentimes have difficulty understanding when we try to give a data analysis about chances for response or progression-free survival. And I think one thing that I would say to patients is don't be afraid to ask your questions again if you don't understand. And I think for providers to try to explain statistics in a way that any person could understand. And so I have to put it in terms of trying to explain population statistics, I think is difficult. When patients ask, what are my chances to respond? We can't tell an individual patient what their chance is. We can say that if we have 100 patients with a similar presentation with this disease taking this therapy, we would expect 50% of those patients to shrink their tumor and 20%, so that'd be 50 out of 100, and then 20 out of 100 might get a complete response, meaning going into remission. So it's important to break those figures down in understandable terms and understand that we really cannot prognosticate for an individual patient. It comes from studies of hundreds of patients, and we can only come up with odds ratios and for a population, not necessarily for an individual patient. Natalie, do you have a typical question in your clinic that you'd like to answer for the group?
Same here. I've tried to think about all of the typical questions I get and made sure that they were previously addressed. The CA-125 question does come up a lot, and usually I take patients back to the Ruston study that showed that even when the CA-125 rose, there was a study that looked at CA-125, and basically in this study, they acted one group of patients, they acted on the CA-125 when it began to rise. And for the other group of patients, they acted only when the CA-125 was confirmed by a CT scan proof of recurrent disease. So for one, they acted early, and the other, they basically waited until you could see disease burden on the CT scan. And they followed these patients for quite some time. Ultimately, they went back and looked at the data, and they said for the group of women for whom they acted early based on that initial rise of CA-125, how did that group overall on average do compared to the ones who waited for proof, if you will, on the CT scan? Turns out there was no difference in survival between the two groups, but the group for whom they started treatment earlier, just based on the CA-125, not surprisingly, that group experienced greater toxicity. So they were exposed to more drugs over time, but not with a survival advantage. So until we have a more sophisticated modern way to look at things, and until we have more targeted agents at our disposal, that's kind of where things are going to fall out. But if I had to be a betting woman, which I'm not, but if I had to, I would say that in the future, we'll have more sophisticated ways to monitor patients, and we will have targeted agents that will identify strategies to further improve upon what we already have in terms of survival. And the combination of these two strategies will synergistically advance survival for women with ovarian cancer. But until then, while we're still using the CA-125, the CA-125 rise without evidence of CT scan in studies has not been shown to increase survival.
And I would echo those comments, but I would also say that, you know, just understand that things change over time. And as you suggested, as we have more targeted agents available and more therapeutic options, of course, it could make a difference with earlier detection of recurrence. And so we have to keep an open mind about that, that one phase 3 study done 15 years ago can't really, you know, define us forever, that there will be changes in technology and new agents available. So, which kind of brings up another idea, and that is, if you're going to get a test or get a study, you have to ask yourself as a patient and a clinician, what are you going to do with the information? And if the answer is the same, no matter what the result of the study is, then you probably didn't need the study. And that comes into play with a question that's been posed on the question line, and that is it better to get is it better to determine the recurrence with a CT scan or a PET scan? I think, you know, better is really not the word. It depends on the circumstance. If a patient is known to have disease that can be seen on a CAT scan already, and you're monitoring lesions for response, then clearly you rarely would need a PET scan. If we're talking about a patient who is considered free of disease, and you're wondering which one will pick up disease better, it's possible that a PET CT scan is more sensitive and can pick up disease a bit earlier. But this gets us back into the question that was just addressed by Dr. McKenzie. And that is, we're not certain that more intense monitoring and early monitoring, depending on the individual circumstance and what the treatment options are, will make a difference. There are false positives with PET scans. It's important to remember. And we have to always factor out the noise in a PET scan. And you have to ask yourself the question, what are you doing with the information? I resort to PET scan in certain circumstances when we've had patients very stable, with no evidence of perhaps intraperitoneal disease and some treated lymphatic disease in lymph nodes only. We sometimes have the option to use targeted radiation therapy for those nodes when we're getting pretty heavily treated with chemotherapy and running out of some options. So a PET scan can be an excellent source of information if we're looking for occult sites of disease in borderline and large lymph nodes to determine, do they harbor cancer or not, without resorting to a biopsy, which can pose some risk and also have its inaccuracies. So there are some specific uses of PET scans, but as a routine monitoring technique on a fixed time interval, probably not very beneficial, very expensive over time, and we run into a lot of resistance with insurance companies about getting repeated PET CT scans, probably for some good reason. I don't know if you have anything else to add to that, Natalie, but the question was, is a PET scan better than a CT scan?
Okay. Is there another question, did you say?
Yeah, I think another question has come up. I'll pose this one to you and have you take it. Is there any potential benefit of trying a platinum-based drug a few years after a patient is determined to be platinum resistant? That's a great and timely question.
So I think we'll both have to answer that. Could a tumor all of a sudden be sensitive to platinum again? So lots of people have tried to think about how to make a tumor platinum sensitive again. And if the tumor itself has mutated enough, might it become platinum sensitive again? And then secondly, what could you add to a platinum drug to enhance the efficacy of said platinum drug with a novel therapeutic agent? So one of the first attempts to do that was Peter Rose with cisplatin and gemcitabine. And in that phase 2 trial, they actually saw that there was the ability to potentially, for some patients, not all, and that's the thing about cancer, because the heterogeneity of tumor cells within the same person, let alone from person to person, varies so much. You're unlikely to have exactly the same result for every cancer cell and every cancer patient. But that was one of the first studies to explore re-challenging with platinum for a potentially platinum-resistant cancer. And there have been other strategies as well, again, to look at that ability. Now, the rule of thumb usually is to explore other drugs that are known to be efficacious that haven't been tried yet before necessarily going back to a platinum for a platinum resistant patient. But like I said, there have been numerous attempts to explore agents in combination with platinums to restore that platinum sensitivity, if you will. And I'll stop there so that Dr. Holloway can talk to you about some of these other strategies.
Well, there's a new theme and recognition, I think, in the clinical trials network of investigators who talk about this issue, that when we talk about platinum resistance, I think it's important to understand that being labeled platinum resistant does not mean you will not respond to therapy. And I think we've always known that. So the odds are down. And so we're coming up with new terminology such as platinum eligible or platinum ineligible. There are some absolutes where a patient may be placed into a platinum ineligible category, and that could be severe platinum allergies resulting in anaphylaxis, requiring a lot of resuscitative medical support. So it kind of becomes an absolute. We have a difficulty ever giving platinum compounds, as some people become very resistant or very allergic. If you're facing renal failure, it becomes difficult to add more platinum therapy. And then for patients who actually progress on platinum-based therapy, so they're actually on platinum-based therapy, growing new tumor or enlarging tumor, that's considered a category of patient that you probably will not re-challenge with platinum. But the definition of platinum resistance is really an older term that's still used quite commonly from Dr. Maury Markman, that categorized patients who had a relapse of disease within 6 months of a platinum-based therapy. But, is there really a difference between someone who relapsed at 5.5 months versus 6.5 months? Probably not. It's a continuum. So it's an arbitrary definition. It does not mean that the patient will not respond to platinum. It just signifies a group of patients who have less of a chance to respond. And when they do respond, it's for a shorter duration of activity. So for the typical mixture of platinum resistant patients who relapse within 6 months, you can get platinum responses 25% to 30% of the time. It's just that the duration of response is usually in the range of 3.5 to 4.5 months. And the toxicity of the repetitive platinum-based therapies grows over time, so that it becomes less palatable to take a more toxic therapy to get only a perhaps 4-month period of response. So the ultimate question was, can a patient with platinum resistant therapy take platinum again? And there is rationale for that. We certainly do have patients who have had a number of single agent therapies and now find themselves 2 years, sometimes 3 years from a platinum doublet therapy. And if they're starting to lose control of disease using various single agent options or phase 2 trial therapies and whatnot, it certainly makes sense to go back and try platinum-based therapy. As Dr. McKenzie noted, we do think that there can be somewhat of a reset, so to speak, that some of these platinum-resistant cells may, through other mutations, develop clones of cells that are more platinum sensitive, and over time, we'll have more activity. So we do that in clinical practice. We do look at the platinum-free interval, how long they've actually been off platinum, even if though they were at one time platinum resistant, may find themselves now a significant time period away. Maybe their previous toxicities have resolved somewhat, like neuropathy or fatigue, and they suddenly become reasonably good candidates for platinum doublet therapy again. And then with respect to the intraperitoneal oncolytic virus phase 3 trial we discussed, these patients are being treated with oncolytic virus and then going back on platinum-based therapy, because we've seen that the oncolytic virus actually reverses platinum resistance. The response rate in these patients is about 55 to 60%. And these are heavily pretreated, multiple line of therapy patients, many of them platinum refractory, in fact, who then have an approximately 50% chance of re-responding to platinum with a median duration of response over 8 months. So there are a number of avenues of research trying to investigate ways to reverse platinum resistance. It is heavily tied with what we call the microimmune environment of the tumor cell, and it's an exciting area of research. So I don't see another question. Natalie and Heather, speaking about survivorship and quality of life issues and maintenance of therapy, do you have any advice about exercise for patients currently undergoing therapy or in their recovery mode immediately after chemotherapy?
I'll start. And of course, Heather, I would love for you to give us some input as well. First of all, one thing that we know through exercise oncology trials and studies is that exercise can help mitigate cancer-related fatigue. And so for those of you who are on treatment or know somebody who is on treatment, and this is not ovarian cancer specific, it's any cancer, exercise, think of exercise and activity kind of like being a rusty tin man. Right? So you're rusty, you're stiff, but then you get the blood circulating. Well, when you get that blood circulating, lots of magical things happen deep down inside, including the mitochondria and muscle mass, all of which equal less cancer-related fatigue, less chemotherapy-related fatigue. So something to keep in mind. Now, let's talk a little bit about the typical ovarian cancer patient. Well, the typical ovarian cancer patient is going to be 60 years old or more, may be deconditioned and not have a lot of exercise capacity. So what can an older cancer patient on chemotherapy do? Walk for 30, 45 minutes. If you can pick up the pace a little bit after walking a couple of weeks, maybe you find that you're less stiff, your joints are less stiff, you have a little bit more energy, a little bit more pep in your step, increase the pace. Chair yoga. You don't need to go to a special place to do chair yoga. If you have access to a computer and you find a video online, there's probably 30, 40 minutes, even 15-minute videos of chair yoga. It doesn't have to be complicated. All cancer centers usually have access or referral base to physical therapy, have the physical therapy assessment. What's your balance like? What ailments do you have? Do you have a bad back? Do you have a bad knee or a hip? Have that same physical therapist assess your balance, assess what's called your functional status, and then have them make recommendations, homework for what you can do. Because all patients are different, they're all going to have limitations. However, there's usually something that you can do, and it will decrease cancer-related fatigue and increase your resilience. And when you increase resilience, it means that your body is stronger to receive more treatment. There's one thing we didn't mention that didn't come up, is that sometimes we have more agents that we can use on the list, but the patient and their performance status deteriorates to a point where we can no longer offer more treatment options. So staying fit and healthy also helps the patient increase their performance status, thereby allowing their clinician to have more time and use more strategies. That was my long-winded answer.
This is Heather. One of the things is knowing your resources. And I agree with all the benefits to exercise during treatment, after treatment. There was a small study that showed exercise outperformed even Ritalin for patients on treatment for cancer-related fatigue. And there's a really great resource that I refer my patients to. It's actually through Penn State. It's called the One Group, ONE. And they have cancer-related exercises online with video tutorials, and they break it down based on questions. And one of the questions is, can you lift a full gallon of milk out of a refrigerator and put it to the table? The other one is, do you walk around your home between tasks? And if you answered yes to both questions, then you go to a different video. So it's an algorithm based, so you get the appropriate video for your performance status. And that's something, these exercises are things that you can do in your home without any additional materials to purchase. And that's a really great start. And if you can't lift that full gallon of milk and get it to the table, they do refer you to physical therapy. And most cancer programs will have a physical therapy department that is comfortable with taking care of cancer patients. And we tend, as oncologists, not to refer as often as we should. There's a lot of studies that suggest that that is something that we need to work on. So being your own advocate and asking for that referral is really important, especially if you have peripheral neuropathy, where it may limit your ability to even walk because your gait pattern has been affected. The physical therapist can help you with your gait pattern so you can regain that function. And, the other thing is, whenever you're thinking about physical therapy, sometimes it's not about walking, but it's maybe my goal is to be able to take care of my grandchildren again, and I can't do that. I'm too tired, or I can't bend down. Whatever that limitation may be that prohibits you from doing what you love to do, if we can get you into the right physical therapist or occupational therapist, they can help you gain that back so you can take control over that. And I think that's really important. And the other resource that I recommend to all of my patients, it's called the Anti-Cancer Lifestyle Program. And it's spelled just like that when you find it, anticancerlifestyle.org. It's free, and they go over ways to reduce your risk of cancer, ways to recover from cancer, and ways to enhance your outcomes during treatment. And lots of resources. They provide the data behind their recommendations. MD Anderson Houston vets the material on there, so it's validated information. And they go through exercise recommendations, dietary recommendations, mindset to how to sustain change, because that tends to be a big issue with our society. and environmental avoidance, because a lot of the things within our environment have carcinogens. Because once you've had cancer, you want to be able to protect yourself, but not only yourself, your family. And when this is kind of off topic, but one thing that I didn't mention is that for a cancer survivor specifically, and especially ovarian cancer, all epithelial ovarian cancer patients are candidates for genetic testing. And that's something that as you progress through, rechecking with the genetic counselors to make sure that updated panel testing is not recommended is important, because that's an evolving field, just like all the other fields with immunotherapy and so forth, is really important. But just being very open and knowing that these types of issues are really important and they need to be brought up at these appointments with your providers.
That brings me to the last thing. So just like the anti-cancer living program at MD Anderson, the HEAL program is based in lifestyle medicine, then the 6 pillars of lifestyle medicine. But one of the things I thought was important, and it's public knowledge that I'm a cancer survivor myself. And so when I created the HEAL program, I created the HEAL program first as a cancer survivor, and then I made it better as an oncologist. And I made it even better as a diplomat of the American College of Lifestyle Medicine. And so one of the things that I added to the HEAL program that is perhaps different than some of the lifestyle-based cancer survivor programs out there is that I added intimacy and sex counseling, because a lot of our adult patients find that to have a full life, regaining intimacy and the ability to be intimate with their significant other is impacted by cancer or cancer treatment. And there's no reason why we can't take the new normal and optimize the new normal for our cancer patients. So that is an additional component of the healthy lifestyle-based program that we have. There are other cancer centers that do the same. Yale has an excellent menopause and intimacy clinic. And I believe that Memorial Sloan Kettering has also worked on one as well.
They do. I actually run this women's sexual health program at Baptist MD Anderson. As a person that treats breast and GYN cancers, I've seen the effects of our therapies and what they do to our patients, and not many people are comfortable with it. Just yesterday, I had a 71-year-old couple that were thrilled to death that somebody actually brought it up. And, we're hopefully going to be able to regain that function because your relationship changed, or maybe your sense of touch changes because of neuropathy, and you don't used to like your feet touched and now you don't. Or maybe it's vaginal dryness or menopause symptoms, but getting to a provider that's comfortable talking about that is really important. And it was something that is near and dear to my heart, and it's probably my favorite part of my job.
Okay, it looks like another question has popped up here. Is there any benefit to going back on PARP, parentheses Lynparza, after recurrence? I'm currently on Avastin for maintenance, but now have a second recurrence. Doctors recommending radiation since it's only one spot in the vaginal fornix. Plan is to continue Avastin during radiation. So the question is there any benefit to going back on a PARP after a recurrence? So I'll take a stab at that and then have Natalie comment on it. If I understand, the patient is on Avastin maintenance, has developed a vaginal cuff recurrence, and you're going to do radiation therapy and stay on it. And then is there any benefit to going on to a PARP? Well, traditionally, the decision about going on Avastin or a PARP inhibitor is made based on the genomics of the tumor at the outset. And I'm going to assume if if this patient is on Avastin maintenance, that they were not, they didn't have a characteristic called homologous repair deficiency, or LOH high, they're LOH low. And typically, if you have a recurrence of disease and it's in a platinum sensitive setting, you would go back on platinum-based therapy, then move on to a PARP inhibitor for maintenance, but not roll onto a PARP inhibitor as treatment or to alter the maintenance. Getting an isolated vaginal cuff recurrence in ovarian cancer is really pretty unusual, though. And, I would wonder if there isn't other disease in other spots. So I'd be a little surprised if that is the only site of recurrence. And of course, I don't know the entire treatment history and how many lines of therapy and all that. But I would be concerned about recurrence in other spots. That would be a little unusual to get an isolated vaginal cuff recurrence in ovarian cancer. Natalie, any thoughts?
So I usually try to categorize things to simplify for our patients. So when we think about a recurrence, is it just in one spot that we can detect? Do we suspect that there's probably miliary disease, tiny little things like Parmesan cheese sprinkled within the abdomen that can't necessarily be detected on imaging studies such as a CT scan? Or is there a lot of tumor? There's a huge tumor burden everywhere. And what toxicity did the patient experience already? And what agents have been recently used? And what options is the patient eligible for? These are all of the things that your clinician is going to take into consideration when making a decision. What are they going to keep in their back pocket to use later for you? And what makes the most sense to use now? These are all of the strategies that clinicians use. So for what appears to be an isolated recurrence where there doesn't appear to be anything else, a clinician may very well choose radiation therapy for that isolated recurrence. Like Dr. Holloway says, if there's suspicion that there's active disease elsewhere beyond the site that's seen, using something that's systemic will be helpful. Whether or not you re-challenge with a PARP, there are studies that have looked at that. They believe that there may be an opportunity to re-challenge with a PARP or a PARP combination strategy. But that data is not fine-tuned yet. And so for now, very much has to be on an individual basis. We don't actually have set guidelines in that space quite yet. We're collecting data. There's more to come in use of PARP and re-challenging with PARP. There will definitely be opportunities to potentially re-challenge with PARP, but through studies, we'll be able to better fine-tune the selection criteria for that strategy. I hope that answers the question.
And in this case example could be someone with multiple recurrences that have been managed successfully, and you just get a vaginal recurrence. Again, it's a bit unusual. And if you think you're getting benefit from the Avastin and other areas, certainly wouldn't be quick to stop it. But typically, you wouldn't just rotate. I'm inferring that the patient has not had a PARP inhibitor before. But the only reason I would switch is if I wish I would have done the PARP in the first place because they're homologous repair deficient, and that might be a rational approach. But you have to know a little bit more about the case to answer that question, I think. So I think I don't see any other questions. I think we're kind of nearing the end of our presentation. I think we have a message from Dr. Diaz on becoming your own advocate and the legislative efforts. Do we have Dr. Diaz on, or is this going to be a recorded message? Do we have Michael Diaz?
Unfortunately, we're experiencing some technical difficulties. I will email the link to view this pre-recorded video following the wrap of our program this evening.
Okay. Well, are there any other questions from the audience? Any other comments? I think if not, we want to thank all of the speakers for participating in this and volunteering your time, and all of the participants for listening and posing questions. I hope that you found this valuable again, and we'll plan to perhaps do this again next year. We'd appreciate any of your comments and advice to make this more beneficial to you, and look forward to doing this again next year. Thank you very much.